Welcome to Prescribing Prosperity with your hosts, John and Alex Soutsos from MedWealth Financial Services, operating through IPC Securities Corporation. In this podcast, we provide unique insights into wealth management, the psychology of financial decisions, and help listeners place the capital markets into perspective. Our aim is to help physicians, business owners, and other medical professionals to live their dream. Life is to live and enjoy, so we'll also cover health and lifestyle-related topics such as food, dining, travel, and unique experiences. Learn how global trends shape our investment strategy as we help you assemble your roadmap to prosperity.
Hello, and welcome to the Prescribing Prosperity podcast with your hosts, John and Alex Soutsos. Gentlemen, good to see you again. How are you?
Doing well, Bill. Very good. Thanks, Bill. How are you doing?
I'm doing great. I'm actually really excited about today's topic because today's topic is one of those topics that rarely has a calm debate about it, neither here in the States or there in Canada. And of course, the topic is healthcare. It's an important topic, and it is a delicate topic. On both sides of the border. And usually, as you have noted, Alex, what begins as a philosophical debate descends really rapidly into some illogical, politically motivated fights without any sort of resolution. And I will add to this a story that I know from having done some work on Richard Nixon's library. Did you know in the United States back in the late 60s, Richard Nixon proposed a universal health care plan for people who were on poverty? It never went to a vote because the most unlikely of political opponents, a man who would usually support this kind of legislation, you would expect, but who hated Richard Nixon so much he didn't want him to get credit for it, Senator Ted Kennedy had it axed out of the bill. So this is a long going fight that has gone on both sides of the border. And I'm excited today because your guest is somebody who has an inside perspective, both as a physician and as a former head of the Ontario Medical Association and a former Canadian Medical Association board member, Shawn Watley. Shawn, good to see you. Glad to have you with us. How are you today?
I'm doing well. Thanks, Bill.
It's really good to have you here. I'm looking forward to this conversation. And with that, I'm going to turn this over to John because John seems to have a personal stake in this conversation.
Yes, I think we all have a personal stake in it, but yes, it's near and dear to my heart for a variety of reasons, which I will not go into in detail. Shawn, the last time I saw you, it was November of 2018, and there were U.S. midterm elections going on the evening you were presenting to my clients. Wow. So much has happened in those in the preceding 6 years, and perhaps you can fill in some of the blanks. But today, to our audience, we're gonna touch the proverbial third rail in public policy discussion in Canada, and that is the universal healthcare system. And as Bill noted, no one better than someone who's inside the system and has had a close-up look and has worked for it, with it, and outside of it to give us some perspective. So, Shawn, perhaps it would be best if you first gave an overview of how the Canadian healthcare system works.
Sure, absolutely. So that's a gigantic question, but just as succinctly as possible, I think if you asked any Canadian, your neighbor, anybody who's really not working inside healthcare, but just, what is Canadian healthcare? They would probably say something like, well, it's free care, it's universal care, it's care when you need it, regardless of ability to pay. And certainly that's the dream that we advertise to the rest of the world, saying this is a good reason to come to Canada, to immigrate to Canada, because you're going to get free care no matter what. So I can dig into that and unpack that more if you want, but those are sort of the key features that Canadians like to highlight when we brag about our system.
Okay, perhaps, Shawn, you can explain how the funding component of the healthcare system works. While
Sure.
Under the provincial jurisdiction, there's still a portion of funding that comes from the federal level. My recollection was the federal government prior to 1994-95 was funding 50% of healthcare through transfer payments. That was cut due to the necessities of an overburdened federal budget in the mid-90s. It was cut from 50% to 25%, which resulted in downloading of expenses at the provincial level down to municipalities. So perhaps you can give some perspective there.
Yeah, so great point. They do share funding. Now, to be clear, when the federal government gives money to the provinces, they expect that the provinces are going to spend that on healthcare. But we have to back up a little bit and dig just for 30 seconds into history. Healthcare is supposed to be a provincial mandate when you look at the Canadian Constitution. So Section 91 and Section 92 separate out what belongs to the feds and what belongs to the provinces. Provinces are just, I'm not sure. Do you have any American listeners, or is this all
Yes.
Canadian?
Yeah, well,
Oh, you
we
do?
will have some American listeners.
Okay, brilliant. So provinces are like states, and our federal government in Canada is analogous to the federal government in the United States. So the federal government is the central authority, and the provincial governments are the more local authority. Now, the provinces were supposed to be in charge of healthcare, according to Section 92 of the Constitution Act. However, the feds have this thing, this power called spending power, federal spending power, which means they can use their ability to raise tax dollars to bribe, and I use that word intentionally, to bribe the provinces to do things that the provinces may not have done otherwise. And so what happened in 1948 is the federal government started with federal health grants, and they said, here's money if you go and build hospitals. And so that's what the provinces did, right? They said, hey, we're getting credit from our local constituents for building hospitals using federal money. And there was a cost sharing arrangement with that. Where we see the 50-50 arrangement start is in 1957 with the Hospital Insurance and Diagnostic Services Act. So build the hospitals in 1948. Then in 1957, the feds say, listen, we're going to pay for 50% of whatever you spend in hospitals. Then fast forward to 1966, the feds say, well, now we're going to pay for 50% of whatever doctors do. So 50% for hospital care, 50% for medical care. And so naturally, the provinces, the provincial members of parliament, were very happy to expand services, build hospitals, add hospital beds, and you just see a massive increase in the amount of care and the infrastructure that's provided. So that gravy train was turned off in 1977 with the first Trudeau government, and that was with the Established Programs Financing Act. So the Fed said, listen, we can't afford this blank check of 50% of whatever you spend on anything. So we're going to change the deal. We're going to change it to, they transferred some tax points, but they switched to block grants based on, it was tied to GDP growth, but mainly tied to population size. So it was at that point, at the end of the 1970s, when the provinces started to panic. They said, we can't afford, how are we going to pay for this gigantic entitlement we built? And we've been fighting over funding ever since. And so today the feds pay about 20 cents on the dollar. Now, to be fair, the feds were paying 50% of hospital and physician services right up until 1977. But since then, we've seen a movement of services outside of hospitals, whereas in 1975, 45% of healthcare spending went to hospitals. Today, only about 24% of the total spend is used up by hospitals. So the nature of medical care has changed, but the funding really hasn't kept up with it. So although I love beating up on the feds for not paying more and for only paying 20% on the total bill and getting to choose the menu, right? It's like they're paying the tip and they get to say what's on the menu. It's still that we can't really expect them to be paying 50% in today's legislative environment.
So how does the funding work at the physician level? Can you explain some of the models that are available for physicians?
Yeah, so just broadly, we could separate docs into specialists and generalists, or family doctors and consultants. About half of the 45,000 or so physicians in Ontario are generalists or family docs, consultants are still paid for the most part on a fee-for-service basis. It's the same as when you go to your accountant or your lawyer. If you go in and you need legal fees, you have to pay for those fees. You don't pay a set rate for the whole year. The government doesn't like fee-for-service because they can't stay on top of costs. The trouble with fee-for-service from the government's perspective is that it incentivizes doctors to provide more care. So patients want more care, doctors want to provide more care, so their incentives are aligned, and you just see an escalation in the number of services that people access, and the number of things that doctors tend to suggest. Well, maybe we should get you a chest X-ray, or maybe I should see you back in a few weeks just to double check. So there's a risk on that end of things. So governments have been struggling since the 1970s to figure out how can we put brakes on this process. And the way they've put brakes on the process is by limiting the number of doctors, limiting the number of hospital beds. But then in the early 2000s, they came up with they implemented a new idea. It really wasn't a new idea. It's been done in other countries, but it's called capitation. Now, capitation is a middle space between fee-for-service and salary on the other hand. Governments could never afford to have all doctors on salary, just because then they would have to pay for their clinic. The government would have to pay for the infrastructure and the capital expenses of clinics and hiring and firing and all the rest. They'd rather leave all that to the docs, but then try to find a way to still not pay them salary. So this middle position is called capitation, where family docs, at least, if they sign up to these capitated models, will get a set fee for a patient for the year. So for example, a young healthy male plays hockey, junior A player, I'm looking at Alex,
Not
would
anymore.
yeah, you might bring in, $140 a year or whatever, but Alex never goes to the doctor. So docs are very happy to sign Alex up to their practice, right? To roster him. And then when Alex does go to the doctor, so if he's in my practice, let's say, I would get a shadow bill of 10% of the service fee. So the service fee is $36 for a general assessment, right? You have pneumonia or something terrible, and I get to bill $37. I'd get $3 on that, more as a tracking code. So there are a whole bunch of subsets within the capitation model, but I'll just end with this. An academic from California put it this way. He said that the three worst ways to pay doctors are fee-for-service, capitation, and salary. And then he unpacks all the different ways to pay them. So certainly there are problems with every one that you choose. My big issue is the problems that end up being harmful for patients. I'm less concerned about something costing a lot for the government because the government said, well, we're going to provide care for everybody. Oh, but now we're changing the rules to compromise access to patients. That really rankles me, but we can unpack that if you want to.
Yeah,
Shawn,
but I just want to ask a quick follow-up question, Dad.
yeah, go ahead.
Regarding the fee-for-service model, based on what you described, it seems like it probably best aligns the patient's needs with the doctor's incentives. My only caveat to that would be, do you find in your experience that it necessitates or it motivates some doctors to just see as many patients as possible without giving them proper attention, just to say that they saw a patient and therefore collect the fee associated with that? So instead of saying, let's say the average doctor sees 30 patients a day. I know it's probably much larger than that, but on a fee for service model, if they can squeeze in an extra 20, obviously that increases their earning 66%. Is there do you ever see that in terms of a misalignment of the incentive for the doctor?
Yeah. So great question. And I'll answer it with a question before I unpack it a little bit. So if you went to a coffee shop and you're paying fee for service for coffee, and they gave you half a cup and threw it at you and splashed it everywhere, and you'd be like, holy smokes, I'm not coming back to your place. I'm out of here. Or if you went to see John Soutsos for financial advice, and he was like, here, do this, get out of here. You'd say, forget it, buddy. And you would put him out of business. The reason that docs can get away. Some docs can get away with what you're talking about, factory medicine, right? Just grind people through fast as possible. Don't even say hi, be a jerk. The only way you could do that is if you ration the number of docs in the system. If you have a more of a free enterprise approach where people actually have to compete to provide services to keep your trust, to make sure that Alex doesn't go to see Dr. John, because I don't want to lose you, Alex, because if I lose you, I'm going out of business. I can't pay for the lease and I can't pay for my staff. And that was the situation we had in the 1970s and the 1980s. In fact, docs were scared to go on vacation in case their pregnant patients would go into labor while they were away. And then their colleague would deliver the baby in the hospital. And then the mom would be like, yeah, well, my doc wasn't here for me. I really like Dr. John. I'm going to go sign up with Dr. John. Forget about Watley. I don't want to see him anymore. So you only really end up with the problem you're describing when you ration the number of docs in the system. And then furthermore, though, you ration the number of docs, and then when you refuse to increase the fee, so just think about it. Someone's coming to see you with a pneumonia or weak and dizzy or chest pain, or usually people come in with 4 problems, and you're getting to bill $37 for that. You have 40% overhead, right? For your lease, your heat, your hydro, your staff, your license, all the rest. And so on that 60, what's 60% of 37? Anyways, on that smaller number, you're using that number to save for retirement and to send your kids to school and to pay your own mortgage and pay your own lease payments on your car that you can't write off, on your personal vehicle or whatever. So you're living off that much smaller number. And then patients wonder, well, why is my doc only able to talk to me for 10 minutes or 5 minutes? Well, $20 doesn't buy you a lot of talking time. So it ends up being really bad for patients, really bad for the doc. It compromises the essential trust in that doctor-patient relationship. And that's what was happening with fee-for-service medicine in primary care at the end of the 1990s and into the 2000s. We had 1.7 million patients without a family doctor in Ontario in the late 1990s because family practice was dying due to fee-for-service medicine. But it's not because of the idea of fee-for-service medicine. It's because the government rationed it and refused to fund it in a way that you could survive practicing in any conscionable way that maintained a relationship with your patient. So great question, but it's not as simple. Right now, if you come out and defend fee-for-service medicine, you're immediately seen as out of touch, you're evil, there must be something twisted with you. I'm a fan of fee-for-service medicine if it's done right and patients have choice.
Yeah. Well,
So
you
when
need a free market system to balance the incentives for the doctor so that way like you said, the service incentive stays on the table.
Totally.
So
Shawn, with respect to the capitation system, my understanding, correct me if I'm wrong, is let's say a doctor has 2,000 patients. The provincial government says, okay, you have 2,000 patients. We're going to pay you X amount for each patient, or we're going to give you a block fund of $750,000 for the year. And then the incentive to the doctor is, I don't want anyone to come. I'm going golfing. Do I have that wrong, or am I correct?
Yeah, so in a worst case scenario, that it's not structured that way, but if you did structure it that way, that's what would happen, and that would be terrible. A full-time practice nowadays is about 1,100 patients, maybe as high as 1,500 patients. 15 to 20 years ago, you had docs with 2,500 patients, even 3,500 patients, but they didn't have the administrative load that we have now. Basically, it's almost a 1-to-1 ratio. Certainly 2-to-1 is really common for clinical time to administrative time. People are sicker, older, but mostly it's the administrative burden where docs are having to spend upwards of 20 hours a week on administrative work. So you just simply can't carry that number of patients anymore. We can get into the nuances of the billing rules and, why, a dentist will have 5 chairs running, whereas a doc has to actually do all the work for each patient in each room. And we can unpack the business aspects of it. But with the capitation models right now, you actually get a distance. So if your patient can't see you and they go to see another doc or they go to a walk-in clinic, you're negated. So 20% of your pay is at risk. Furthermore, if your patients if they're outside use, it's called outside use, is high, your whole group gets penalized. So there are some fairly strong disincentives for behaving in the way that you describe. Having said that, if you're in a small community where patients again have no choice, you have a monopoly, and all of the docs in town decide to form one great big group where they're all in cahoots and they all go on holidays, or they all go on holidays and just leave Alex holding the fort,
Right.
while they're all on vacation. Yeah, patients are going to get terrible service. And I know of one or two communities in Ontario where things like that happen. It's almost like a cabal that they set up. But that has to be dealt with, right? The trouble is, as soon as you try to centrally control something, then you need more central control and more oversight and more intervention. I think it's much better to allow patients choice. If they don't like the service they're getting, I'm going to change doctors. There are problems with that too, because it encourages doctors to do things just because they're so afraid of losing the patient. So that can bring patients to harm as well. But there's always a trade-off, right? In whatever
Right.
system you.
But
I know,
Shawn,
just you spoke about not getting the service. Yeah, we've experienced it here. Both my mom and my wife at different times have had issues with their doctors, being unable to get in and see them whenever they require care. I remember my wife several times, calling the office, and they would say to her, "Oh, well, we can book you in for an appointment next month." Well, what good is that? Like,
Yeah, yeah,
I'll be
yeah,
better or I'll be dead. One of the two. So,
yeah, yeah.
like,
Well,
what good is it?
yeah, it's terrible. It really is terrible. And it's all a reflection of the way the system is set up, right? It's not set up to increase the number of services you are able to access. It's set up so that it can be rationally planned and there are solid expectations. They can budget this from year to year. And that's not good for patients. I don't think it's good for docs. It compromises the doctor-patient relationship. It decreases trust. It's just, anyways, I don't want to sound too negative about it. There are positive ways. We need to be hopeful.
yeah, I think you got to call it the way it is, regardless of whether it's good or bad. Shawn, how would you describe the current state of our universal Canadian healthcare system? Is it the envy of the world, like the politicians tell us?
Yeah, that's a great question. So even the politicians actually have started to say things out loud that you just would never have heard before. So you think of Prime Minister Justin Trudeau in his Christmas address, December 2022, and he was asked by Rosie Barton about, it was actually in reference to the funding agreement that he was really dragging his feet on. So every so often they have to renew their funding agreement with the provinces. And he said, quote, "There's no sense putting more money into a broken system." The
Hmm.
prime minister. I mean, no sitting prime minister has ever said that. Now, Jane Philpott in 2017, when she was Minister of Health, she was speaking to a group of us at the Canadian Medical Association. She was listing some of the myths about healthcare. And one of the things she said is, it is a myth that Canada has the greatest healthcare system in the world. And so there was a marked change around 2014. That was the first Commonwealth Fund study that came out, a fairly left-leaning think tank in the States, or a study research center, and they looked at the top systems in the most wealthy countries in the world, and they ranked Canada second last for access, quality, service, equity, all these different measures that they looked
How,
at.
how long is that list, Shawn? Is that 10 countries, 20 countries,
It was
30?
only 11 in that study, and we were ranked 11 as 10th out of 11, and they put the United States last. So it was
Hmm.
a double whammy because we were ranked at the bottom of their list, but most importantly, we were ranked at the bottom with the United States. And so once that happened, basically, the refuse hit the fan and everybody got really upset about it. They repeated the study in 2017. We bumped up one place, France fell a bit, and then in 2021 we fell again to second last place. But the OECD, WHO, multiple other people have put out these rankings, and we're never in. Maybe we can get in the top third out of 100 countries. But for the amount of money that we spend, we're just not getting. Canadians are underinsured.
Right.
Right. So if you were to classify it on the basis of a return on investment, you would say it would not be a blue chip investment in your eyes, Shawn.
Run away.
All right. Fair enough. Well, so Shawn, your first book came out in 2016 and it was titled No More Lethal Waits: 10 Steps to Transform Canada's Emergency Departments. What motivated you to begin this particular project? Was there a particular event or experience that acted as a catalyst for the book?
Yeah, a great question. It was embarrassment. So I had lived in the area that we're in for about 10 years at that point. And you start to get to know the community, right? And I just got tired of cringing every time one of our friends or family or acquaintances would say, "Oh yeah, I was in the emerge last night." And you just cringe. Oh, here it comes. And I waited 6 hours, and then I waited 10 hours, and then this, and then this. And I just was like, this is so terrible. So I think that's what really motivated me first, was just embarrassment. We have to change this. This has to be better. So that was the major thing. The other major thing that happened was we were at a point where we had no leadership. Our department was in such bad shape. Our previous chief said, I can't keep going. I think he had been there 6 years and wasn't getting the support he needed, and just said, and he gave the admin lots of warning. He said, I got to get out of here. A year, you got to find a replacement. No replacement. They kept advertising. And so finally we had no chief for our department. We had about 75,000 visits at that point a year, one of the larger departments in the country. Now we're up over 100,000, 125,000, I believe. I don't work in that emergency department anymore, but one of the larger departments in the country. And so our department had no leadership. And so the chief of staff was going to have to make our call schedule. And I panicked. I thought, oh my gosh, she doesn't know anything about the call schedule. Not that it's hard to put names in boxes, but there's more to a call schedule than doing that. You have to know what people's lives are like and all the rest. So I said, listen, I'll do this. I'll do this as interim medical director and chief, because no one else wanted to do it. And mostly just so that my life wouldn't be ruined. So I did that for a year. I was able to recruit a whole bunch of people. We filled all the holes in our schedule. We had 63 open shifts at that point in a 2-month schedule. We were able to get rid of all the recruitment agencies, all the mercenary people. We saved the hospital a ton of money and had all the night shifts covered, all the day shifts covered. And I kind of said, okay, there, I'm done. Give it back to you. Now find someone to do this job. And so they went out and recruited for about 6 months, and they couldn't find the person they wanted. They kept saying, we want you to do the job. And I was like, I'm not doing this job. Forget it. I don't want to do this job, because they had no secretary, no office support. I think you had a computer. They did give you a computer, but basically no support at all. And they would pay you a day a week based on a 20-year-old pay cycle. I said, this is a 5-day-a-week job. I've spent easily 5 days a week trying to fill this schedule. And I said, you need to figure out how you're going to pay someone to do that, but it's not going to be me. And so make a long story short, they came back and said, listen, we're going to fund this 5 days a week. We're going to pay you 3 days a week. You're going to hire someone else to do it 2 days a week. And anyways, that was the end of the story. And we got a secretary and admin support and an office. And then we were able to actually make some change.
Shawn, was there a
And
fallout to your book's publication and your comments?
Not as much as you would expect. Certainly it has become a cult classic within the emergency medicine community. Some people who are really sort of deep inside the union movement, the organized labor movement, don't like it at all. And they'll say, oh, yeah, I've read his book. I know what he thinks. But overall, especially people who aren't in medicine read it and just say, yeah, this is common sense. Like, why wouldn't you run your department like a restaurant, right? If there are no customers, why do you have so many people there? If more customers come because the Leaf game just finished and everybody's coming to your restaurant to celebrate, yeah, you'd call in a whole bunch more staff from home. So a lot of people find that to be very obvious, but people in medicine bristle at changing that conceptual paradigm, the set of norms and behaviors that they've always lived with.
Why do you think that is? Why is the organized labor component so opposed to some of these changes?
So great question, and I want to be a little bit careful because I don't want to really beat up on anyone, but our system is built on an iron triangle. So you're maybe familiar with the concept of corporatism, where you have this rigid closed shop between government, big business, and labor. Well, in Canada, we have an iron triangle between government, the unions, and the medical profession. And we all try to have veto power and make sure that no change happens unless we all benefit, right? So if you're going to do something for the nurses,
Right.
it better benefit me as well. Or if you're going to benefit the docs, then the nurses say, well, you got to better benefit me. And so everybody's there trying to say no. And the government obviously has the ultimate veto power. So when you're making changes, people have fought for decades for the current status quo. And any change, people are very, very suspicious. Well, what does this mean for us? Well, maybe we won't need as many triage nurses, or maybe we're going to have to work harder, or maybe you're going to compromise the labor negotiations. And so there's just the initial instinct is to fight for more for yourself, right? It's a fixed pie. We want more and for ourselves, and we want to fight for what we've already attained. And it makes it
Right.
very, very hard to get change. It's possible, as my book describes, but it's hard to make change.
It sounds like the former Soviet Union's Politburo, frankly.
I wasn't there. I don't know.
Not to offend anyone.
Yeah, that's
But
right. That's right.
what's the average wait time for a patient moving through the Canadian healthcare system right now, Shawn?
Yeah, so it depends on the procedure you're talking about. So I try desperately to find a glass half full story for everything. And so if you have a concrete diagnosis where it would embarrass the system if we didn't have great service. So for example, heart attack. So all you need is a few stickers on your chest and you get an electronic printout that says John's having a heart attack or Alex is having a heart attack. The clock is ticking, right? Heart attack, time to opening your arteries. It's very embarrassing if we went on the national stage or the world stage and said, yeah, we don't provide heart attack treatment until the next day or whenever. So you have to be within minutes. And same for trauma care around Toronto, right? Around a large city where you can have a helicopter service. Well, those are internationally accepted standards. When you get a cancer diagnosis, when you finally get a piece of tissue under a microscope and someone says, yes, you have high-grade breast cancer, the clock is ticking. It looks very bad for Canada if we can't provide a timely service for that. The trouble is, most things in medicine don't work like that. You don't get on the treadmill, right? You have abdominal pain and you have this test and that test and this test. And then eventually you find, oh, it's pancreatic cancer. Or you have a sore knee and you put up with it in hockey for a year and then it swells every time after hockey. You have to change your behavior and you see a doc and you get an x-ray and then you see your doc again. So that lag time is really, really long, but it's less embarrassing for the government because it's more hidden. It's only rarely where you'll see, relatively rarely compared to the number of 320,000 patient interactions per day in Ontario before COVID. Well, we don't hear 320,000 media stories about people waiting. You only hear oh, there was a 4-year wait to see a neurologist over in Kingston, and that makes the headlines. Or there was a over 600-day wait for knee replacement down in the St. Thomas area, and then that makes the headlines. Well, governments can swoop in and fix that problem really quickly. So once it becomes a political problem, they can solve it. It's a long-winded answer to say it's not easy just to say this is the wait time X. Fraser Institute, I believe their latest wait time to see a specialist was up over 27 weeks. When they started looking at this in the 1990s, it was 9.3 weeks, so under 10 weeks. But even that is kind of it's more of a blunt instrument.
Right.
I would suggest we should ask patients, when do you want to be seen? Most people want to be seen within a few days or next week,
Right.
right? If someone tells you, hey, I'm worried you have a brain tumor, you want to be seen really fast. Or, hey, I'm worried about this lump in your pelvis. Like you don't want to wait weeks.
Yeah.
Sean, a number of years ago, when we were interested in getting an MRI for a family member, the wait was just for an MRI, 6 to 9 months. And our dog had a medical issue and went to the vet, and he got an MRI the next day. So here in Ontario, our pets get better medical care than, or at least better access to certain medical care than human beings. So any comments about that? And has it improved in the last few years?
Yeah, so no, we can't compare to pets. I mean, yeah, you could only wish for that kind of care. But this'll rankle or rot your socks a bit. And so you can Google this article. It's on the CBC 2017. CBC reported on from the Manitoba Auditor General report on MRI wait times, since you mentioned MRI wait times. And the Auditor General found that for MRIs, athletes can get one the next day. Quote, government officials, donors, so hospital donors, people that give money to the hospital, or people working in the healthcare system can get same or next day. People injured at work, so WSIB, could get an MRI within 20 days. And everyone else could get an MRI within 23 weeks.
But Sean, I thought it was a system that was equal for everyone.
So go Google that, CBC article 2017, the Auditor General. You know, and talking about good care for everyone, we lost the moral high ground on this in the late 1990s. So what's one of the pillars of Canadian Medicare is that equal care for all, regardless of ability to pay, right? Sounds like the Marxist slogan from each according to everyone according to his need, from each according to his ability to pay. I've mangled that, but that's a classic Marxist phrase. But the New England Journal of Medicine in 1999, and this is my favorite article, I share it all the time. There have been many articles like it ever since, but this is the best one out there. They looked at what happens to people after a heart attack in Ontario, and they looked at 51,591 patients, and they separated them into whether you lived in the highest quartile socioeconomic, so the richest neighborhoods or the poorest neighborhoods. And they found that there was a 23% increase rate of use of tests after heart attack and a 45% decrease in waiting time between patients living in neighborhoods with the highest and the lowest quintile. So we keep saying, oh, equal care for all, regardless of ability to pay. But if you happen to live in a wealthy neighborhood, you're going to get care and wait half as long for it and get 23% more services. And we've known this since 1999. And there have been many studies since, looking at socioeconomic status, education, language, and all sorts of barriers, whether you live in Toronto versus whether you live in the outskirts. Yeah, no, we don't provide equal care for all. That's a total myth.
Yeah, to give more context to the story that my dad shared, it was me. I was suffering from concussion issues when I was playing hockey, and they'd done a CT scan on me. It wasn't getting better, and so they did a CT scan, and there was an anomaly on the CT scan, and so they wanted to verify whether or not it was a bleed or if it was just an instrument error or something. And anyway, it's your brain. You want to make sure that there's nothing going on. And when they said 6 to 9 months, we said, hold on 1 second. You just said that there might be a small bleed there. You're okay with letting that sit for 6 to 9 months.
Yeah.
And so we ended up driving down to Buffalo and got an MRI down there the next day, and it was actually quite a nice experience.
It was good.
But
Like you're fine.
oh yeah,
Well, yeah, let me
Yeah.
tell this. Let me tell the story. So this is around the time when Krispy Kreme donuts first expanded
Oh.
into Canada, and it happened. There happens to be a location in Mississauga near us, and every time I would drive by, that's when I used to eat sugar. I don't eat sugar anymore, but back then it was something that was very appealing. So I would drive by Krispy Kreme donuts in Mississauga, and there was a perpetual lineup. I'm not going to wait in a lineup to eat a friggin' donut, but I was curious. Anyway, so this transpired, and I said to Alexander, we're going to Buffalo. So we hop in the car, get to Buffalo, pull into the private clinic, and just beside the private clinic, there's a Krispy Kreme donut shop with no lineup.
Wow.
So we
Wow.
went into the MRI clinic. They treated us like gold. On the exit, I said, when will the doctor in Toronto get the results? He says, the doctor will have your results before you arrive back in Toronto. And here's the CD of the image. And it was a great experience. And as we exited, went to Krispy Kreme Donuts, got a couple of dozen donuts, and had my first Krispy Kreme donut at that time. So
Wow.
it was a great experience, to answer your question.
Yeah, well, over 200,000 people a year are taking advantage of that experience. There are whole hospitals built in the States and clinics and outside of the United States that advertise to Canadians. I have a number of stories myself of friends who have, including patients, but I'm thinking of one of our friends right now whose mom, she's passed away now, just recently. But she had a lump in her abdomen, and they said, listen, we need to get a CAT scan for you. With the wait, I think it was going to be 6 or 8 months at that point. They drove to Buffalo, got the scan, and got her home and on treatment that ended up prolonging her life for another 10, 15 years because they went and got that treatment. The trouble is you don't know in advance, right? Is this going to be one of those scans that helps me to stay alive? Or not. And in retrospect, you don't know either, right?
No.
If you stay here and the scan is delayed, well, did the delay cause problems or did it not cause problems? And so patients are left in a quandary, and thankfully it's becoming a lot easier and a lot more cost effective for Canadians just to drive south, get it done, come on back. Here's the
So
images. Get going.
So this is the criticism I get when I have these conversations is, we wouldn't want a U.S. style two-tier healthcare system. Yet here we are as Canadians giving our money every year in very large sums to the U.S. system for those of us prepared to pay. Whereas if there was a private alternative here in Canada, that money could stay in Canada and provide jobs to Canadians. And so it is, in my opinion, irrational to stop Canada from introducing a parallel private care system for those who want to pull themselves out of the public queue and therefore make that queue shorter for the public, and then pay for it separate. Even though they're paying taxes for the public healthcare system, people are still prepared to pay separately to get immediate care. Doesn't that make sense?
It does, and certainly this kind of discussion is a lot more common. I do a lot of talk radio, and people are very comfortable about talking about this now. Usually, if you frame it as a 407, which is a toll road for listeners outside of the Toronto area, versus the regular 400 series highways, people don't have a problem with the 407 existing as long as it doesn't make traffic worse on 400, 404, or 401, right? So as long as the public highways aren't made any worse, and in fact, if they're made better, so there's less traffic on them because a few people go on the paid highway, people are really okay with that. So the old ideological resistance to anything outside of the state, I think is waning away, and people are realizing that, yeah, this isn't really realistic. We have mixed approaches to fertility care in Ontario, and it works well, and so they're not having the same panic. Having said that, politicians still have the same panic. They don't want to have the discussion for the most part.
Right. Well, just we're gonna take a slight dip in the negative here, Shawn, and then I promise you we're gonna pull it back out of the negative here. So I'll ask the question in two parts just to kind of get it out of the way. Number one, how many patients die every year waiting for care in Canada? Number two, what do you attribute as the primary cause for the long wait times that we have here? Is it simply a lack of capacity, a forced constraint of capacity, as you mentioned earlier, or are there other factors at play?
Yeah. So the dying on waiting, the best research we have out there is actually done by secondstreet.org group. In 2023, they published it. In fact, they consulted with me when they were setting up that research. And what they did is they did a Freedom of Information request to all the provinces and territories in Canada and said, give us the numbers on how many people died waiting for cataract or cardiac surgery, how many people died waiting for a hip and knee surgery. And to make a long story short, it was very hard to get that data. So governments either didn't want to give it or they just didn't track it.
Right.
But even beyond that, even if governments did keep careful data on how many people died for each one of these procedures, you'd still need to parse out almost at a patient level what was going on. Did they die because they were sick and they were going to die? Or did they die because there was a material impact from the waiting time imposed? Second Street came out with a number of around 17,400, but even that number, it's there's so many ways it could go. I suspect it's too small,
Mhm.
but yeah, it's an impossible question to ask.
Yeah. It's a little bit like, it reminds me of the during the dark ages of COVID, when they were talking about COVID deaths, and anybody who tested positive with COVID, it got hit by a bus, so they tested positive with COVID, it's COVID death. And
Yeah.
like you said,
Yeah.
it's difficult to work through the data and actually know what the counterfactual is, like what would have happened to the patient had, X occurred.
Right.
Was this the variable that was at cause, or was it another variable? So what about the wait times then? What's the reason why we have the wait times? Is it simply just the lack of capacity, or would you say there's something else at play?
If you look at the government's argument in the recent Cambie surgical case right out in BC, the government argued that actually wait times are not caused by governments at all. It's got nothing to do with rationing or lack of capacity. It's entirely because doctors mismanage waiting lists. And there are also other people who have argued that, well, actually, doctors like a long waiting list because it increases the amount of clout they have when negotiating with the government. So there's all sorts of just outrageous ideas out there saying why there are waiting lists that it, which I think are, again, outrageous. They're total baloney. We didn't have waits in the late 70s and 80s. So, for example, if you needed to transfer someone to your hospital because they had a broken hip up in Huntsville and you needed to fix them down in Newmarket, the doc on call up there would call the surgeon at our hospital and say, hey, I've got, someone with a broken hip and we need to ship them out. Can we ship them out? And the surgeon would say, yeah, send them down. No questions asked, send them down, done. Today, you can't do that. You can say, well, I'm okay. I'm available. I could do the surgery, but you have to speak with bed allocation. And then bed allocation says, well, actually, our hospital is full. We're not accepting any transfers, or we don't have any nurses on call to do we're not going to open the operating room on the weekend because we have cyclical shutdowns, or we're during the summer shutdown period or the holiday shutdown period. So it's all about rationing. And just to give you some detail on that, so in 1990 in Ontario, we had 33,403 beds, which is 3.2 beds per 1,000 population. In 2003, we had 18,781 beds. So fewer beds. We're down to 1.5 beds per 1,000 population. In 2017, we were down to 18,571 beds. So even fewer, down to 1.3 per 1,000 population. In that time, the population grew by 36%. So we went from 33,400 beds in 1990, 33,400 in 1990, down to 18,500 in 2017. Drop the beds, increase the population. In the 1970s, we had 6.9 beds per 1,000 population, so 6.92 in 1976. Today, Canada as a whole, Ontario is much worse than Canada. Canada as a whole, we have 2.5 beds per 1,000 population. So that's usually how they describe the numbers, right? How many beds per 1,000. We're 26th out of 28 countries in the OECD. The average number in the OECD is 4.3. So we're almost half the number of beds that is average in the OECD. Germany has 8 beds per 1,000. Japan has something like 11 or 12 or 13, like huge numbers of beds. per 1,000 population. So when you talk about, is it capacity? Yeah, capacity is a huge problem. I would also argue it's an issue with management and a whole bunch of other things. But number one, Canadians are underinsured. The governments are rationing to a massive degree, not just to a small degree.
Dad, you wanted to jump in?
No, he answered my question. I was going to ask
Okay.
how our peers on the global stage compare in terms of bed capacity.
Right.
Just for a little bit of clarity, we hear this term about our hospital is full. That doesn't actually mean there aren't rooms or beds. It just means there isn't enough staff for those rooms and beds. Correct, Shawn?
Yeah, bed means a staffed bed. So a
Right.
bed that has a nurse attached to it.
Right.
Okay. All right. Go
And
ahead,
so,
Alexander.
yeah, so then that actually dovetails nicely into one of the things that I wanted to discuss with you, Shawn, was the fact that over the last 40 years, our population, I'm speaking specifically in the GTA, and I believe the numbers are comparable in Ontario, and I don't know how the extrapolation would work on a national scale, but within the GTA, our population has doubled in the last 40 years. In that time, my observation has been that the healthcare system has not grown in a commensurate manner. By that I mean we have not had any net new hospitals be constructed during that time period. I know there have been some hospitals which have been, relocated or rebuilt. I'm thinking of Oakville, Trafalgar, or Humber Hospital. Those were hospitals that were modernized and rebuilt in different locations, and that's one thing. That's some capacity increase. But on the whole, we have not increased our capacity in the same degree as the population growth. And so I wanted to, I guess that you've partially answered it, but I just want to reiterate, is that just a function of that is a conscious decision on the government's part to restrict capacity in order to manage costs? Is that correct?
Oh, absolutely. Yeah. No, capacity is directly related to utilization. Utilization is just a fancy word for saying the number of services that people access or the number of services that we provide. And on top of that, you can talk about the change in demography. So in the 1960s, when we were building the final pillar of our Medicare system, so that was the Medical Care Act, the average age in Canada was in the mid-20s, about 24, 25, I believe, in 1965. Just a few years ago, average age in Canada was 43. In 1965, we had, I believe it was 6.7%, might be getting this wrong, of the population was over 65 years old. Just a few years ago, over around 15% of the population is over 65 years old. And so there are many, many markers you can look at: the average age, the percentage of the population that are seniors. You can look at the number of services that we can provide to people, the types of services we can provide. So the amount of care that is expected as normal or the standard of care per person, especially per old person, is massively increased compared to what it was even 30 years ago. And
Right.
on top of that, you look at we mentioned administrative burden before. So certainly community docs can't provide the number of services or can't care for the number of patients that they could in the old days, just because there are so many more expectations on them. So you've got a doubling of the population. I don't know what percentage or whether it's halving or quartering of the amount of capacity. Docs aren't able to carry even maybe a third of the number of patients that they used to care for before. And all of this is due to regulatory, administrative, bureaucratic, legislative decisions. So we don't have an absolute lack of physicians in Canada, aside for some subspecialties like pediatric neurology, but for the big family docs, general surgeons, we don't have an absolute lack of physicians. We have a relative lack of physicians due to an absolute lack of freedom to be able to innovate and find different ways to provide care for our patients.
No, that makes a lot of sense, Shawn. And one thing that I've said to people, I used to work in consulting, and we did a couple of healthcare projects. And one of the takeaways that I ended up having was, it seemed as though we had an inverted pyramid for the Canadian healthcare system, where the burden, as you mentioned, the average age moving up from mid-20s to now mid-40s. And as you know, the older population has a disproportionate or places a disproportionate burden on the healthcare system. It's just natural as we get older, we tend to require more care. And so, we have this increasingly large base at the top, which is being supported by a very, very narrow peak at the bottom, in terms of a shrinking young population, which is providing the revenue for the system. And so it seems an inevitability to me from the work that we did that this current system as it's currently constructed is not sustainable over the long term.
Yeah, a fancy term for what you just described is the dependency ratio, right? How many producers to consumers do you have? And our dependency ratio is just going off the charts. We aren't going to be able to pay for what we're offering, and yeah, it's been looking dire for a long time, but now yeah, it's really coming home to roost for sure.
Right.
And excuse me, what I find amazing is the current medical system, and this is not restricted just to Canada. I think this applies universally, even in all parts of the world, including the OECD nations, is medical care is based on treating acute illness as opposed to preventative care and providing education to the public about changes they can make privately to their diet and activity regimen to avoid having to enter the healthcare system. Is anyone in the federal bureaucracy attempting, or in the political process attempting to make such a shift, or are they drowning so badly that they can't even contemplate that?
Yeah. So you're touching on I mean, all of these questions are fantastic, and you're touching on a gigantic issue. So prevention is good, I would argue, because it's morally right. So I should tell you to stop smoking, lose weight, eat better, exercise, because it's good for you. But the literature is pretty clear that it does not save us money. So in the 1980s, we used to think that we could prevent our way to healthcare savings. And that was a big, Tommy Douglas was big on that. We need preventative medicine. You can still Google him and listen to him on YouTube talking about it. That doesn't save the system. In fact, excuse me, it might cost a lot more just to do that. And you may not even save that many lives. So the classic example is in smoking. You actually end up costing the system much more. If you can convince a smoker to stop smoking, they're going to live a lot longer and suffer from a whole bunch of chronic illnesses. It's morally the right thing to do, right? It's morally the right thing to do. I think it's better for the individual, but it's not better for the cost to the system. Furthermore, go ahead. You're going to say something.
I was just going to say it's not good for the cost to a system that's centrally planned. But if the system were not centrally planned, it would make a hell of a lot of sense, wouldn't it?
Well, then you get into deductibles and incentives, and yeah, so that's another rabbit hole we could go down for sure. But I'd like to end with this comment. And a lot of people say, "Oh, we don't have a healthcare system; we have a sickness care system," and so they've set up a straw man, and then they attack the straw man. So the term health care only became popular in the 1940s. The first use of it, I believe, was around 1905, 1906. I'm going to put this in my next book, actually. So don't steal it from me if you're writing a book. But governments became very, very interested in healthcare for a lot of the reasons you're talking about, right? Preventative medicine. How can we have healthy soldiers? How can we have healthy workers that will stay on the job and build our economy and pay lots of taxes and make a nice, big, strong country, and especially so we could win wars? Medicine is 3,000 years old at least. It has always been focused on illness. I'm here to fix your illness and to fix your leg when you break it. If I see a kid with an ear infection, I say, yeah, it looks like an ear infection. Looks like you've tried, to let nature run its course. It's probably not a virus. Let's go ahead with some antibiotics. I don't want to see the kid when they're healthy, right? If you're healthy, I don't say you are now healthy. Go back and, live long and prosper. I don't. I just treat your illness, and then I got to see everybody else who's got illness too. So it's a completely different focus and function, this traditional approach to diagnosis and treatment. Now, modern medicine has been hijacked by the public health end of things. I'm not saying that there isn't wisdom. Dr. Snow pulled the pump off of the water pump on Broad Street and ended the cholera epidemic in London in 18, I forget what the year it was, 1840s, I believe. Don't quote me on that. And so absolutely, if we find that there are cholera bacteria causing an outbreak from a particular contaminated well, like that's some really cool public health work there, science-based public health. But that's completely different from public health now trying to change medicine into public health, where you have an ethic that's based on populations instead of an ethic that's based on individuals. So instead of me trying to do what's best for you as an individual, I'm now trying to decrease the diabetes in the whole population or decrease the high blood pressure in the whole population. It's a completely different ethic. So a deontological normative ethic versus a consequentialist or a utilitarian based ethic. So just be aware that there are major minefields there. Yes to prevention. I would argue that we should have preventative health nurses, public health nurses doing prevention, or you could have AI doing prevention, right? Put in your age and your weight and your risk factors and your past medical history, and AI could spit out what you should do. Hey, you need to run more or relax more or whatever. We don't need to send someone to 11 years of university and years of training for me now to tell you, hey, you're eating too many Krispy Kreme donuts.
No, I gave them up a long time ago. Shawn, let's transition you to your second book, which is titled When Politics Come Before Patients. This book was released in 2020. How does this book differ and expand on the findings from your first book?
So the end of my first book, I said we need to get political. And so this book is really a deep dive into diagnosing why is our system the way it is. And the first half of it looks at the promises we've made, the mantras, for example, care regardless of ability to pay. Well, actually privileged patients get care, or we're so efficient, we're actually not that efficient. Or it's built on the myths that doctors would give one kind of care to rich patients and another kind of care to poor patients. And that's why we needed Medicare. Well, it's total garbage. We had standards of care back into the 19th century. It was unethical. You would lose your license if you advocated terrible care to poor people and great care to rich people. Tommy Douglas was not telling the truth there. And then so that's the first half of the book. The second half of the book digs into why exactly are we struggling? And so I look at things like legal instrumentalism, where governments pass laws to try to improve performance. It would be like Tim Hortons saying, hey, Premier Ford, can you pass a law to improve the customer service at Tim Hortons all across Ontario? I mean, it's just absurd. And, I see Alex, he's a consultant. Like, business people get this right away. They just say what are you serious? Legislation to improve management? So that's an example. Or you talk about managerialism, where the idea that management can always do a better job no matter what, and no matter what the field is. And so we just need to have more and more and more managers everywhere, because they will always be smarter and do a better job than people who actually know the work themselves. That may be the case in some areas. I love managers. I've spent a lot of my time in management, but it falls down over and over if we use that as a blunt instrument to improve everything. So that's what that book's about. I had hoped to create one gigantic book looking at these are the problems, and now let's look at all the solutions. But I'm actually kind of glad that I didn't put it in one big book, because COVID threw a spanner in the works, and I've had to change my approach a little bit for this next book I'm working on right now.
Thanks for that, Shawn. What's the best way we can quantify patient outcomes?
So it depends, again, on what you're looking for. So people will come to the defense of Canada all the time and say, look how great our perinatal mortality rates are, right? So the classic numbers are how many babies die after birth, how many moms die during childbirth, how many people, what's the life expectancy, right? Are men living until 83 and women until 85 in your country, or are they all dying in their 60s? And we use those sort of rough and dirty comparisons to make ourselves feel better, that we're doing so much better than the United States or wherever. those are the traditional ways that we measure. I'm not sure they're good enough, because I think most people would agree right now that perinatal mortality is often related to maternal nutrition, right? If they have access to fruits and vegetables. Longevity is a combination of lifestyle plus genetics. And in Canada, you tend to freeze to death if you don't stay somewhat active and, repair the roof every now and then. Whereas other countries, you don't even need a house to stay alive. And so if that's sort of your whole lifestyle, right from day one, of not having to pay so much rigorous attention to just survival, right? Where I grew up in Thunder Bay, you couldn't survive unless you were kind of active and thoughtful and
Right. Right.
proactive and delayed gratification, do the work on your house before you
Played hockey on
go
the
party.
pond.
Yes, exactly.
Have patient outcomes improved or regressed in the last couple of decades?
They continue to improve. Again, this is touching on a larger question. There's a great book, Rise and Fall of Modern Medicine, by LeFanu. It won some prize. I can't remember which prize it won. It was written in the 1990s, I believe, and then it was re-released in the 2000s at some point. But he looks at sort of the golden era of medicine in the middle of the 20th century, antibiotics and all the whiz-bang things that we can do. But he argues that since the 1970s, really, we haven't come up with anything transformative. We had heart transplants in the 60s. We had percutaneous, opening your arteries after a heart attack. Even in the late 1960s, it didn't become mainstream until into the 1970s. But for the last 3-4 decades, it's been, okay, now we have another drug for your cholesterol. It works a bit better than the old ones. We have a new antipsychotic, works a little bit better than the old ones. There are definitely innovations out there, so proteomics and personalized medicine and gene therapy, but we haven't seen sort of massive transformations in specific diseases, you will, some of the childhood illnesses where people aren't dying from cystic fibrosis like they used to. But overall, it's been a much slower increase. And some people are arguing that we're going to start seeing a decrease in longevity, because nowadays we live on our Krispy Kremes and Diet Cokes, whereas our grandparents didn't have the money to buy Krispy Kreme and Diet Coke. So they were out gardening or whatever and lived longer because of that.
Shawn, on the subject of the pandemic, did the pandemic change your perspective on the healthcare system in any way, or did it further cement the notion that Canadian healthcare system is in need of deep reform?
Well, the first few weeks of the pandemic, again, I always try to be glass half full. I never believe it with all the negative things I've said, but the first few weeks of the pandemic, I was really excited. I was like, wow, governments basically gave carte blanche to the hospitals and said, listen, we've got something bad here. Get ready for the worst. And so all the local hospitals were pulling their vents out of storage. So, the machines that you use to help people breathe when they can't breathe on their own. They sent out messages to the community, to the docs and nurses saying, hey, we may need your help in the ICU. Get ready, all hands on deck. It was like a very short window of creativity and generative ideas and innovation, and let's get ready to put this fire out. So I was very hopeful there. That hope evaporated almost immediately. All of a sudden, people said, oh yeah, no, all the infectious disease stuff that we've known for 100 years, forget it all. This is brand new. Virus? No. Never mind viruses. Never mind infections. Never mind natural immunity. That's evil. You're clearly messed up if you would mention something as silly as natural immunity. That doesn't exist anymore for this virus. And of course, we know that it does exist now, and people are starting to say, well, yeah, eventually you do get natural immunity. So I became profoundly depressed, not psychologically or psychiatrically, but just with the medical profession, with the medical industrial complex, with government's involvement. And so that's why I said earlier that I'm actually glad that I didn't publish solutions, because the solutions that at least I was thinking about in the late, 2018 to 2020 were really on the assumption that we had a greater institutional capacity than we do within, government capacity, medical capacity within the medical profession, capacity within the actual organizations themselves, like hospitals and clinics. And I just don't think we do. We've lost a lot of our fundamental ability to balance risk, think rationally, think scientifically, make decisions on the fly. Now that's not to say there aren't opportunities we can recover, but it's going to take a different approach than just simply saying, okay, let's get everybody together and fix this.
So you mentioned about the ventilators. I just saw an article that the federal government is selling all our expensively purchased ventilators from the pandemic for scrap, and we've wasted, I don't know what the number is, $10 billion or something of that nature. Any comments on that?
Yeah, it's the title of my book, When Politics Comes Before Patients. You're in dangerous territory. Just like I got the best smile of the whole podcast from Alex when I said, would you pass a law to improve service at Tim Hortons in Canada? No, you wouldn't. You would never go to government and say, listen, the service at my Tim Hortons is terrible. Premier Ford, I need you to pass a law. No, keep the government out of that, please. And I'm not saying give all the power to the doctors, no, but we need to allow things to happen in such a way that patients have choice. They know what they're getting into. They can see quality outcomes. So, just like you have reporting for the cost of your cell phone or the cost of your insurance plans, or the outcomes of, the gas mileage on your vehicle, like you can have some standardized reporting. But ultimately, it's about, do I trust this person that I'm working with? Not, do I trust this bureaucratic system that's been perfectly designed? There are no perfectly designed systems. You can't ask Premier Ford. I feel bad picking on him. I actually pick someone else. You can't ask the chief in the government to set up a system for great service at Tim Hortons. It's just ludicrous, and yet we do.
Yeah. Well, Shawn, this was a fascinating topic. We didn't even get into some of the topics that we wanted to discuss today. So perhaps if you'd be willing, we'd love to have you back on again to try and talk about maybe some potential solutions. I know you said that that's going to be a portion of your next book, but if you're willing, we'd love to have you come on again and delve deeper into this very important discussion.
Yeah, happy to anytime.
Appreciate it. Thank you. And Bill, we're going to turn it back over to you.
Yeah, I could let this conversation keep going on and on and on and on and on. In fact, the question in my mind that you can answer when you come back, Shawn, is how do you balance this whole argument in terms of politics and data? Because data seems to get in the way of everybody's politics, and we don't seem to give enough weight to the data. So I'm interested in the answer to that question, or that dilemma, I guess I should say, when this conversation continues. Guys, thanks so much for facilitating it. It's a great conversation, and it is honestly, it's an intimate and an important conversation for everybody involved in the discussion. John and Alex, I'll leave you with, just for people who are listening to the podcast who think that you might be somebody that they want to have a conversation with, how can they get a hold of you? What's the best way?
Best ways to go to our website, medwealth.ca. That's med-wealth.ca, or send us an email at info@medwealth.ca.
Fantastic. Thanks so much. For those of you who are listening for the first time, hit the follow button. That way you'll be a subscriber. That way you don't have to wonder about when and where John and Alex drop their next episode. You will be notified because you are a subscriber to the podcast. Thanks so much for taking the time to listen today. I'm Bill Tucker. On behalf of everybody at MedWealth, I want to thank you for listening and encourage you to go out and make today a great day. You can. It's your choice. Thanks so much for listening.
Thank you for listening to Prescribing Prosperity. Visit our website at med-wealth.ca. That's med-wealth.ca for more information or to connect with us for a consultation. Don't forget to click the follow button to be notified when new episodes become available. The information covered and posted represents the views and opinions of the hosts and their guests and does not necessarily represent the views or opinions of IPC Securities Corporation. The content has been made available for informational and educational purposes only. The content is not intended to be a substitute for professional investment advice. Always seek the advice of a qualified and licensed financial service provider with any questions you may have regarding your investment or retirement planning. MedWealth Financial Services can provide a private consultation to help you determine the suitability of any guidance discussed on the show.